So this morning I'm going to talk about robotic spine surgery, which is an emerging technology which is just starting to build up ahead of steam, and which we have started to do at Greenwich Hospital. And specifically, we're talking about the Globus Excelsius GPS system, which the hospital purchased, which is the navigation system. And I'm not any kind of paid consultant for Globus. I have no interest in this. I just want to say a word about the Da Vinci robot. That's been at the hospital since 2015, and that has multiple applications listed here. The key with this is it works through a body cavity, and with spine, we generally don't have a body cavity to work through. So this technology doesn't really apply to us. The surgeon works remotely there using hand controls. This thing can sew up a grape like this is demonstrating here, which is pretty cool. But that's different than our robotic surgery. Robotic surgery for us means specifically for placement of pedicle screws. And pedicle screws, image here, are the primary means for achieving fixation if you need stabilization and fusion. And commonly they're used from C7 to the sacrum, so most of the spine. And multiple indications include degenerative disease, tumor, trauma, deformity, and infection. This is just an illustrative case. This is a woman who had a prior surgery and developed significant instability at L4-5 with spondylolisthesis, misalignment, nerve compression, pain, and weakness, and so needed further surgery. And so she had a fusion procedure with pedicle screws at L4, L5, and S1, as well as iliac screws. And so that's the kind of thing we're doing pedicle screws for. This is just a little review of the anatomy, the individual vertebral bodies. Does this show up or no? The individual vertebral bodies stack up on top of each other, and the spinal canal is formed as sort of a tube inside the spine. Did you say yes or no? Yes, okay. So this is the cross section, this is the spinal canal, this is the pedicle, and this is the pedicle here, and then on a lateral view, this is the pedicle here. So that's where we're putting the screw, and inside is where either the spinal cord or the spinal nerves reside. And this just shows you different trajectories for pedicle screws, and it shows you in the three planes. There's a couple different ways you can do it, but it's a fairly narrow window for placing things properly. This is what happens when you don't do it properly, not my patient. This screw is completely in the spinal canal, it's totally missed the pedicle, and the problem is that's going to either hit the spinal cord or the nerves in the lumbar spine, and that is a bad day in the operating room. So we want to try to avoid this. So the Excelsius GPS unit has several components. It has a tracking camera here, and there's a touch screen that we use to interface. This is the robotic arm, which has a guide at the end of it for the instrumentation. But I just want to show you what we have done before using the robot. So this is the Stealth Station FluoroNav, where basically the X-ray machine is brought in and it's tracked by a camera in relationship to a reference frame on the patient. And so the X-rays that are taken can be fed into the computer system, and then we can use them for navigation off of the images. So like this is the computer telling us where our instrument is in relation to the anatomy. And what's good about this is it's fast and there's minimal radiation exposure, but you only have two-dimensional imaging, and there's some potential for some inaccuracy. Another thing we do frequently is biplanar fluoroscopy, which is basically two X-ray machines taking frontal and lateral images in live time. And it works really well, it's very accurate and pretty fast. There's a fair amount of radiation exposure to the doctor and the OR staff, which would be better to avoid, and you can only get 2D imaging on it. And if the anatomy is complicated, sometimes it's difficult, but this is what we ONS surgeons use for every minimally invasive lumbar fusion that we do. And then this is the O-arm, which is basically an intraoperative CAT scan, and it's brought into the field and it actually closes here around the patient, and then images are taken, and those can be fed directly into a navigation system. And the advantage of that is you get 3D imaging with axial views, but the image quality from this is quite poor, so it's limited. In terms of 3D imaging, I mean this is a cross-sectional view of the pedicle and a projection of the screw being placed into it. You don't get that with the X-ray view. And also with CT imaging, you have very precise delineation of all the borders of the bone, which is very helpful. So this is the Globus machine. So the robot arm has a guide, and all the instruments go through that guide. And basically the robot arm moves to where it needs to be and doesn't change for that screw. And then once you get that in position, if it's properly positioned, then it's very hard to miss. So this preoperatively, we take x-rays, well actually no, intraoperatively we take x-rays with a reference tracker on the x-ray machine, and we feed that information into the computer system. And then you match that up with either a preoperative CAT scan or, well, with a preoperative CAT scan, and then you can navigate off of those images. The software merges the x-ray and the CAT scan together so that you can navigate off the CAT scan. And it does it very quickly, and it works very well. This is a drill which is tracked. These are little balls here that are reference markers for the camera to see, so that the camera can tell the computer where the drill is at all times. And all the instruments are tracked in this way. These are the reference frames. There's 2 that go on the patient, and these provide a point of reference for the computer system to know where the patient is in relation to all the other instrumentation. Generally, these require separate incisions depending on exactly what you're doing. And this is an actual picture from last week of the touch screen during the surgery, and it's draped so that it's sterile, so that the surgeon can interact with it. You can change the trajectory, select the next trajectory. There's different ways to manipulate the information, but the computer tells you where the instrument here, so that here is the screw being placed, and the computer is telling you where it is in relation to the information, and that in relation to the anatomy, and that updates continuously. These are just better views of what we did this week, showing you where the trajectories are in the axial view, and the lateral view, and the coronal view. This is a short video I made of Paul Apostolides this week, when we were doing an open lumbar fusion, and he's putting in the pedicle screws using the robot. So at this point, previously we've had a pre-op CT scan, which has been fed into the computer system, and then the surgeon has selected trajectories for each screw that's going to be placed and stored those in the computer system. And then once the patient's in the room and the reference frame is on, x-rays are taken and then fed into the computer system, and that's merged with the CT scan to allow guidance off the CT scan. So then, the robot arm is directed based on the trajectory to the position it's supposed to be in, and once it's there, it's locked and everything goes through that arm. So here he's using the drill initially to create a hole in the pedicle as a starting point, and then now he's going to use a tap, which is also guided, which basically cuts threads in the bone to allow for screw placement. And here you can see on the screen, this is actually a projection of the tap in real time in relation to the trajectory that's planned for the screw, and you can see that in all 3 planes, so you know exactly where you are. And then, so once that's done, the screw is placed, and here's Doris keeping up very well with Dr. Apostolides, who's often very fast. And so the screw is being placed, and again, we're going to track that on there, and that'll be it. Now, the coolest part is once it's done, and you want to do the next screw, so now he touches the touch screen, and now the robot arm moves to the next pedicle, and then it locks into position there, and then that allows you to place the next screw. So what are the advantages? It can be used with pre-op CT scan, intra-op CT scan, or intraoperative fluoroscopy. It's especially useful when the anatomy is complicated, and you can get 3D imaging. And it also, importantly, it establishes a single trajectory for each screw, and you can't alter that by outside factors. This is what I mean by difficult anatomy, the scoliosis case here. If you were using X-ray, you'd have to get a separate image for each bone, essentially, because the plane changes for all of them. And so that would be very time-consuming and not easy. If you have a pretty straight spine, a straightforward case, you can get several vertebrae in one picture, and that's something that is more suited to X-ray imaging. Again, this is the 3D imaging, so it's the axial view here that's important that we don't get with the X-ray. With the fixed trajectory, the problem when we put pedicle screws in, depending on how we do it, there's different techniques we use, and it's essentially freehand with image guidance, meaning that we can move our hand wherever we want, but we try to line it up with the image and get it in the right place. But there are things like bone density and soft tissue that will often redirect you, and sometimes that can force you off course. And so with the arm, everything goes through that, and the trajectory never changes. And I think that's an important advantage and advancement for this system. So what are the disadvantages? It's expensive, it's slower than biplanar fluoroscopy, it's supposed to be extremely accurate. Their initial studies said 100% accuracy, which is pretty impressive, but until that's proven to me in the real world, I don't necessarily believe it. You have some limitations of trajectory based on the soft tissue, and it changes the workflow in the OR. So we change the order of how we do things, and it's a little bit disruptive for the staff and the surgeon. And then it also requires the additional incisions for the reference frame, particularly in minimally invasive surgery. So is it really necessary? So just like, does this dog really need that GPS to find the stick over there? So I think it's useful, and I think it will turn out to be technology that we stick with, and it'll get improved over time. I think for a complicated case where the anatomy is difficult, I think it's going to be very useful. For minimally invasive surgery, the way I do it, I now have to add 2 more incisions, and there are issues with getting it lined up properly for minimally invasive surgery for technical reasons. So, I don't know that I'm going to start using this for minimally invasive surgery, or at least frequently, but there is the advantage, the primary advantage of it versus the X-ray machines is the exposure to radiation for the staff. And although studies have shown generally that the amount of radiation that OR staff get is safe, you never really know for sure. And if I could minimize that, I would like to. So that is all. Thank you.